So, hello friends. So, I'll be talking on this topic ICU protocols. So, this talk I use it as a training for newly inducted nurses and doctors in Nagaland. So, we did a program for Nagaland doctors and nurses. So, that's where I picked up this topic to cover how we go about creating protocols, and we are handholding them towards certain protocols in tele ICU work that we have engaged with them. So, to understand what do we mean by definition of protocol? So, the protocol definition is to make detailed plan of establishing diagnosis, investigations, and treatment steps. And this establishing the diagnosis, investigations, and treatment is collated largely from accepted scientific evidence as standard of care. So, obviously, one can challenge the type of protocol that one would have created, but largely that is accepted as a standard of care based on scientific evidence is taken as steps towards creating a protocol. So obviously, when a topic like this you are talking, there may be at least hundreds of protocols in ICU. So I just picked up few protocols which are of relevance. So there are around five protocols that I picked up when I was engaged in training these newly inducted doctors and nurses in Nagaland. So today I'll be in this recording. I'll not be doing respiratory failure because there are separate videos for all of these conditions, and respiratory failure is a large segment. So there is a separate video on that you can refer. There is a separate video even on the fluid stewardship, but I'll only talk on salient components which should be considered as a part of protocol, and protocol for liver failure, protocol for status epilepticus, and snake bite. So these are the certain clinical dimensions that I covered. But as I said, I won't be dwelling into each and every component of this topic. So things that are important to establish a protocol in a place and things that are expected to be known by the healthcare personnel caring for the patients is what I'll be talking on. So this is again, I've just put very figuratively that you can create protocol for anything and everything in ICU because there can be protocol that can be created for traumatic brain injury, subdural hemorrhage, stroke. You can create protocol for myxedema, coma, thyrotoxicosis, sepsis, surgical, post-surgical care, transfusion protocols, and you can create protocols for burns, for drug toxicity, alcohol withdrawal, protocols for all acute coronary syndrome, pulmonary embolism, ARDS, liver failure, pancreatitis, adrenal insufficiency, venous. So basically, I'm putting this figure to say that you can literally create protocol for anything and everything in ICU. These are all typical ICU conditions where we would sort of tend to create protocol. So the first one I'll take you through is the fluid therapy protocol that I just took the doctors and nurses through. So any fluid resuscitation in ICU means it's a large volume of fluid given rapidly in a short period of time. The intent is to restore blood volume and restore blood pressure and mean arterial pressure. So the whole intent of restoring blood volume and blood pressure is to ensure adequate oxygen delivery to the tissues are happening. But why we say that we need to have a protocol is because overdoing any of these can be dangerous, and underdoing any of these fluid resuscitation also can be dangerous. And it is important to understand the role of maintenance fluid in ICU is minimal. So there's no, if someone does not need fluid, there's no need to keep giving uh, IV fluid infusion of 75 ml for 100 ml and so on and so forth. So if you're giving fluids, it is with an intent that you're improving the blood volume. It is with an intent to improve the oxygen delivery. So there are four Ds with regards to fluid resuscitation. So one is the type of fluid, and one is the duration for which you would give the fluid. The third one is the dose of fluid, and the fourth one is the de-resuscitation. Because we have understood that over resuscitation causes more harm than under resuscitation. So once you have resuscitated, it is important to remove the excess fluid. That's what we call as de-resuscitation. So this is again just a graph to show all the different types of fluids that we use in ICU and different constituents of these fluids we use. And the commonest one we use, even with the current available evidence, is the 0.9% saline or normal saline, which we use is pretty much safe to be used in any of the clinical condition as a resuscitative fluid. And there are this balanced solution. The only advantage is this balanced solution have less chloride because more chloride has shown to cause worsening of acidosis. It causes hyperchloremic acidosis. So in a situation where chlorides are increasing, you can consider switching over to balanced solution. So we'll talk with regards to fluid protocol in the setting of common condition that we see is the septic shock. So the definition is, as you know, it's a life-threatening organ dysfunction due to dysregulated host response to any infection. It can be viral infection or it can be bacterial infection. And largely for sepsis and septic shock, we follow this surviving sepsis sort of a guideline to create protocol. So in that, there is 1 hour bundle where the suggestion is to give 30 ml per kg as a fluid bolus for someone who comes with septic shock. So this one can debate because 30 ml per kg it is a very high dose because if it is a 50 kg individual, it will be 1.5 liter as a bolus. So people have debated, but that is what we have largely agreed as the initial fluid bolus. If things are not improving, then we start vasopressor. And as we are giving fluid resuscitation, one needs to measure lactate because the protocol will be based on the lactate measurement. And to see if lactate is getting better after your fluid resuscitation, then you are expected to send 2 sets of blood culture followed by administration of antibiotics. So all this is called as 1 hour bundle. Within 1 hour, you need to give fluids. And if blood pressure is not improved, can consider starting vasopressors, need to check lactates, need to send blood cultures and start appropriate antibiotics called 1 hour bundle. And as I said, sepsis or septic shock, as the definition says, is a life-threatening organ dysfunction due to. So, what are all the organ dysfunctions that can happen in sepsis? So, someone can have brain that is affected, where there can be confused drowsiness or obtundation. In heart, if you say heart is involved, they should have tachycardia or hypotension. MAP less than 65 is considered as a cardiac dysfunction. Or if lungs are involved, then the PaO2 by FiO2 should have reduced and they must be needing oxygen. And liver being affected is reflected with increase in the liver enzymes and bilirubin. And acute kidney injury is when they have creatinine high or urine output coming down. And in blood components, if they have low platelets or coagulopathy, platelets less than 150, is an organ dysfunction. So when we say life-threatening organ dysfunction, it can be any of these dysfunctions. It can be obtundation, it can be hypotension, it can be someone needing oxygen, it can be a high bilirubin, or it can be with acute kidney injury. So, so these are the things that you would take into consideration when you are labeling someone as sepsis and septic shock. And then what is the protocol that we follow? So the protocol broadly, you can divide it into whether patient has mean arterial pressure more than 65 or it is less than 65. If mean arterial pressure is more than 65, then you are expected to obviously look into lactate. You can't be happy saying, okay, MAP is more than 65, I don't need to give fluids. You need to check lactate and you need to check LV function. So upfront, one needs to do an echo to look at how is your LV function doing. If lactate is more than 2 millimoles per liter and LV function is good, it means still there is need for fluid. Although the MAP is more than 65, you cannot relax and say, patient is euvolemic, we don't need to resuscitate this patient. If lactate is more than 2, it indicates there is some degree of hypoperfusion, they need fluid resuscitation. So give fluid at 30 ml per kg in 1 hour or whatever, some fluid allocate has to be given. The initial resuscitation is 30 ml per kg. If lactate is less than 2 millimoles with MAP more than 65, then you can just closely monitor and reassess the patient whether they are getting better. Now, the second scenario is where MAP is less than 65. Even in less than 65, you follow the same protocol. You have to check lactate, check LV function. So the key message in this is upfront, one needs to do an echo to assess LV function is the message. And you need to look at lactate. MAP alone will not tell you whether they're adequately euvolemic or hypovolemic and so on and so forth. So if it is less than 65, you look for capillary refill time. If it is less than 2 seconds, it is normal. If it is more than 4 seconds, it is abnormal. So check lactate. If capillary refill is abnormal, they need fluid, give fluid bolus. And concurrently, at this point of time, you would consider starting vasopressors, either norepinephrine or vasopressin. And when you're considering starting vasopressors, this is despite after fluid resuscitation, blood pressure has not improved. It's time that you should consider putting an invasive blood pressure monitoring with intraarterial line. The arterial line needs to be placed at a point of time where you think that vasopressor has to be initiated. Then you look at lactate clearance, whether lactate is coming down or not. If lactate clearance is present, which means lactate is coming down, assess volume responsiveness and continue fluid resuscitation. So repeat serum lactate after 2 hours. If it is more than 20% clearance, if serum lactate has come down to more than 20%, then it means they have fluid responsiveness. And then you see if MAP is less than 65. If MAP is less than 60 or 65, where there is more than 20% of serum lactate clearance, then you assess for fluid responsiveness with passive leg rising test. Or you can do IVC diameter or IVC collapsibility index. So these can be used as adjuncts to determine whether your patient is still going to respond to the fluids. Because once your lactate clearance is more than 20%, it indicates to you there is some fluid responsiveness. Then in resource limited setting, you can do delta pulse pressure, where you look at the pulse pressure in supine position, and then you put the head down and you do a passive leg rising. Once you raise the legs, there is an auto fluid bolus of around 250 ml. Then leave it for 60 to 90 seconds and measure the blood pressure, look at the pulse pressure. If the pulse pressure has increased to more than 15%, then it means that there may be fluid responsiveness. But if lactate clearance has happened more than 20%, and if MAP is more than 60 to 65, then you don't need to give more fluid. Although lactate clearance has happened, it indicates fluid response. But if MAP is good, closely monitor and reassess and look for any organ dysfunction. So this is about in a spontaneous breathing. Suppose your patient is intubated and mechanically ventilated, then you have to look at these indices. You can look at LVOT, velocity time integral, or you can check for pulse pressure variation, or you can look for IVC distensibility index or IVC variability index as tools to identify whether someone is fluid responsive. And if these are positive, if IVC distensibility index is more or variability index is more than 50%, or pulse pressure variation is more than 13%, or LVOT VTI change is more than 12%, then it means that they're fluid responsive and you may have to give fluids. So another important thing is, whilst you are looking at these dynamic indices of LVOT VTI, it is also important to look at other bedside clinical and lab indicators which are reflective of fluid responsiveness, because one needs to see in the zeal and enthusiasm of you giving fluids based on this dynamic test, look at other routine variables, whether heart rate is coming down, blood pressure is improving, whether urine output is increasing, and whether acidosis is getting better, lactate is coming down, hematocrit is coming down, liver enzymes coming down, whether bun is coming down, whether peripheries are getting warm, or sensorium is improving. So the only message I'm trying to give in this is, don't fixate yourself only to passive leg rising and all these dynamic indices. Look at other common intuitive variables like heart rate, blood pressure, urine output, lactate, sensorium, acidosis, and all these innate sort of variables we are so much attuned to see if they're getting better. And if fluid non-responsiveness after this, then obviously you have to start, because there's no more room for fluids. So you have to start, you would have started norepinephrine and vasopressin, you have to consider starting septic dose steroids, IV hydrocortisone, 200 mg as an infusion of 24 hours. And then you may have to start considering second line vasopressor, which is possibly vasopressin. And even after this, again assess LV function. If it is a normal LV function, consider vasopressin. If LV is dysfunctional, if LV function is down, then you may have to consider initiating on inotropic drug like dobutamine or adrenaline. So this is the protocol that we have created, and this was used extensively during COVID time for sepsis septic shock. So this is the protocol we can sort of adhere to, which has a sound evidence base to following this. So summary is amount and composition of fluid impact outcome. Good to understand the fluid components in the body, and good to understand what are all the different fluids that can be used. Current evidence do not favor the use of colloids, because colloids is known to show an acute kidney injury. Albumin, no evidence to use as a fluid therapy except few conditions. Crystalloids, 0.9% saline is more physiological, and you can continue to use normal saline. Balanced solution versus saline, there is no difference. And post hemodynamic stabilization, one needs to achieve net negative balance or net neutral balance at day 3. CVP has no role, and dynamic indices more useful. So this is a sort of a summary statements that you can keep in mind when you're resuscitating patients with septic shock. So that's about the fluid protocol. Then very quickly we'll move to the liver failure protocol. So the definition of liver failure is someone who has encephalopathy INR more than 1.5 with no previously existing liver illness in last 6 months. There should not be any autoimmune hepatitis. They should not have any Wilson's, or there should not be any vertical transmission. So liver failure can be categorized into three variants. Hyperacute is where liver failure occurs within 7 days. Acute is where it is 7 days to 28 days, and subacute is 28 days to 6 months. So the etiology, so when you're following a protocol, you need to ascertain what are the cause of the liver failure. So the commonest cause is acetaminophen or drug-induced INH, can be mushroom poisoning or halothane. And the other common causes is all the viruses, hepatitis A, hepatitis B, hepatitis BE, herpes simplex, or metabolic conditions like Wilson's, alpha-1 antitrypsin deficiency, autoimmune, or acute fatty liver of pregnancy. Then there are certain vascular causes and malignancies. So these are some of the causes of fulminant liver failure. Some of the rarer causes are shock and heat stroke. And many a times there may be cryptogenic where there is no cause that can be established. So this is just a US data of 1,321 patients. The commonest cause of liver failure there was found to be paracetamol. In India, I'm told it is the viral hepatitis causing liver failure, which is more commoner. And as you see, the second most common is indeterminate. And the third is other idiosyncratic drug reaction with other drugs. And hepatitis B was the fourth commonest cause. So the key thing in fulminant liver failure is to identify a place where you can refer the patient where liver transplant is done. That is the first step in the sort of understanding how you approach liver failure, because 25% of patients with acute liver failure may need transplant and they need to be sent to transplant center. And 40 to 50% of the patients where the etiology indicates that they have a poor prognosis will need liver transplant. So when do patients with liver failure need liver transplant? Any other secondary organ dysfunction is setting in. If they're getting encephalopathic, if they're getting hypotensive, if they are having acute kidney injury, or if they're going into coagulopathy, or if gas exchange is getting worse, any multi-organ dysfunction or any other organ dysfunction is setting in is an indicator that they need liver transplant. If INR is more than 2 or grade 2 hepatic encephalopathy, one should start thinking of possible need of liver transplant. And high risk patients are one who are more than 45 years old or less than 10 years, or etiology which indicates poor prognosis is one of the reasons that you would think of referring them to liver transplant center, or someone who gets intubated and mechanically ventilated. So any patients who are going into organ dysfunction, where you're anticipating that they're getting worse with encephalopathy, they need to be intubated and mechanically ventilated. And all these patients should be having a background of dextrose infusion, because the commonest problem they have is they develop hypoglycemia and then they'll have seizures, and that will cause or perpetuate worsening of brain edema, because as it is, they'll be developing brain edema. And we need to take precautions that we prevent hypoglycemia at any cost for these patients. So the King's College criteria for liver transplant is for paracetamol, there are two categories. One is paracetamol overdose and non-paracetamol. For paracetamol, the easiest way is pH less than 7.3 is the indication for transplant, or where PT is more than 100 seconds with INR more than 6.5 or creat more than 3.4, or someone who has encephalopathy grade 3 to grade 4. So easy to remember. In paracetamol, if they are developing acidosis, that is an indication that they should go for transplant. So INR more than 6.5, or if they're going to acute kidney injury or encephalopathy. For non-paracetamol, the transplant criteria is based mainly on INR. So if it is a non-drug, hepatitis B, INR more than 6.5 is a criteria for transplant, or any of these, or 3 out of 5 of these criteria, where INR is more than 3.5, bilirubin more than 17.4, or encephalopathy present for more than 7 days, and encephalopathy onset after the jaundice more than 7 days. So these are some of the criteria which is even now considered as a standard criteria for sending patients for transplant. So mortality in acute liver failure, the main mortality, as I said, even the indication for transplant is any secondary organ dysfunction that is setting in is a reason for transplant, because multi-organ dysfunction is the commonest cause of mortality in liver failure. And second commonest cause is infection, secondary infection. Third commonest cause is intracranial hemorrhage. And fourth is GI bleed. So mortality is shown to reduce from more than 80% to 33% in last 25 years due to the evolution of liver transplant that has happened. And even the bleeding risk has come down from 25% to less than 5% because of the advances in managing these patients. And intracranial hemorrhage as a cause remains at 20 to 25%. And the commonest cause for multi-organ dysfunction in liver failure is the first response that they have, which leads to organ dysfunction. Infections, 90% of the liver transplant have infections, and commonest cause is the lung. 50% of them will have lung infection, 22% is shown to have urinary tract infection, 12% is known to have some CRBSI due to catheters in place. So this is the only condition where patients are fulminant liver failure. Prophylactic antibiotics is something that are shown to reduce the risk of infections in these patients. And there should be a good surveillance to look for very preemptively to look for any infection by sending surveillance blood cultures and surveillance imaging to preemptively to see if anyone is developing infections. And this is one condition where intensivists can be little liberal with antibiotic prophylaxis in someone who has fulminant liver failure, because you see here, as per the studies, 90% of them tend to have infection. And empiric antibiotics can be considered in someone where there is a progressive worsening of liver failure in terms of progressive hepatic encephalopathy, AKI, or MUDS. And these are referenced from these articles. So the protocol in liver failure is, it starts with airway, breathing and circulation. So if somebody is getting encephalopathic, you need to secure the airway by intubating early on rather than delaying. And as I said, re-emphasizing, they need to be on some sort of a dextrose infusion to prevent any hypoglycemia and seizures, because seizures is very, very bad. As it is, they'll be developing brain edema. If they develop seizures, brain edema gets perpetuated and gets rapidly worse. And serial clinical examinations have to be done to assess whether encephalopathy is getting better or worse. And serial clinical examination should be looked into whether they're having worsening brain edema that is happening. Whilst you are doing this, protocol should include sending off routine investigations like CBC, KFT, LFT, coax, which are all very intuitive to every intensivist, sending ABG, imaging, and screening cultures. It may be blood culture, urine culture, DPT culture, so on and so forth, to look for any sort of a possible infections in a very preemptive way. And as you're doing this, look for any criteria that you would think that patient needs liver transplant. If your center is not a liver transplant, then these patients have to be immediately referred to liver transplant if INR is increasing, if encephalopathy is setting in, acidosis is setting in, or other organ dysfunction is setting in, AKI is setting in, then you have no business to keep them in a non-transplant center. They need to be referred to liver transplant center early on to save the life of these patients. But if liver transplant is not available in the area, like I did this talk for Nagaland, if it is not available, then you have to continue supportive measures like dextrose infusion and take stringent measures to reduce the risk of measures, and start on some anti-edema measures to reduce this brain edema, because all fulminants die because of worsening organ dysfunction and brain edema. You saw intracranial hypertension is the third leading cause of death. So you need to keep this in mind, start off on hypertonic saline, mannitol, or so on and so forth to reduce the brain edema. And very closely, they need to be monitored for all the vitals in ICU, and hope and pray they improve. But the definitive management is to transfer to liver transplant. So that's about fulminant liver failure as a protocol. So it starts with airway, breathing, circulation, then starts with dextrose infusion and measures to reduce the risk of infection, and sending routine investigations and preventing hypoglycemia would be the key tenets of liver failure management. So we'll just quickly move to status epilepticus, which is also a common condition that we see. So in protocol, when you're treating, you need to know the etiology. Etiology can be all the structural problems in the brain, trauma, or autoimmune meningitis, or infective meningitis, or encephalitis. Autoimmune meningoencephalitis is due to antibodies to potassium gated channels, or NMDA receptors. That is the commonest cause of autoimmune meningitis. Or neuroinfections, or any tumors or strokes or bleeds, any of these can cause status. 53% of the status epilepticus is known to occur due to non-compliance to anti-epileptic drugs, and it can be due to alcohol withdrawal as well. And metabolic disorders are also the common causes for status epilepticus or drug toxicity, and it can be due to cardiac cause like arrhythmias. And there are entities like new onset refractory status epilepticus or febrile induced refractory epilepticus. So these are some of the conditions which have recently been incorporated as the cause. So just pictorially, I put it as the commonest cause. So as intuitively it will say commonest cause would be the structural brain metabolic, but as you see, the largest number is due to non-compliance with the anti-epileptic drug, and 15% it can be unknown. So this was just a study from US hospital in 154 patients with status epilepticus. Drug withdrawal was the commonest cause, followed by alcohol, followed by drug toxicity and neuroinfection. So this was the US data. So drug withdrawal was the commonest cause. So someone comes with status epilepticus, what is the protocol? Just you have to ensure you give 50%, 50 ml dextrose. Yeah, if you do not have ways to look whether there is a hypoglycemia, just give 50%, 50 ml dextrose with thiamine, 100 mg. After this, lorazepam 4 mg IV stat has to be given. And if seizures are not aborting in 10 minutes, we have to give a repeat of 2 mg IV of lorazepam. After this, they need to be loaded with phenytoin 20 mg per kg at 50 mg per minute, or you can consider phosphenytoin at a dose of 15 to 20 milligram phenytoin equivalents per kg. And this has to be, and if seizure is not aborting even with phenytoin 20 mg per kg, you could repeat with the phenytoin of 5 to 10 mg per kg or phosphenytoin of 5 to 10 phenytoin equivalents per kg IV. If seizure is still not aborted, one can start midazolam at 0.2 mg IV stat per kg, followed by 0.1 to 2 mg per kg per hour. Or you can consider starting propofol 1 to 2 mg per kg IV stat, followed by 2 to 10 mg per kg per hour. And after this, they need to be put on some sort of a neuromonitoring, and EEG has to be done to see whether the seizure is completely aborted or whether they are in some non-convulsive status. So EEG is mandatory after aborting the seizures with these medications. So after this, it is important to investigate and treat the underlying cause for seizure. It is not important, it is not enough that you just abort the seizures with lorazepam, phenytoin, and propofol and midazolam. It is important to establish what is the cause, investigate the cause, and treat the cause, and manage the complications. And if patient is seizure free for 24 hours, then one can look at tapering off the infusion and slowly weaning off the infusions that patient may be put on. So this is in brief about the protocol that one could set up in ICU to immediately treat the seizures, and then you can start other oral medications as deemed appropriate. So the last one, we'll just talk about protocol for snake bite. So as I said, in snake bite, one needs to look for any fang mark or any bleeding at the site, and there can be swelling at the site. But if it is a crate bite, you wouldn't see the fang mark. So that is something one needs to know. 70% of the snake bites are non-venomous. And after the snake bite, the key aspect in the protocol is that you do not mobilize the limb. So the first step is to immobilize the limb by keeping any stick that may be there or any sort of a contraption that you have to make sure that the limb is made immobile and cover it with some sort of a crepe bandage. So our whole effort is not to tie this bandage very tightly because there'll be swelling, there'll be impeding of the venous flow and arterial flow, and our whole aim is to ensure that the circulation is happening without impeding of the venous flow. The whole aim is only to immobilize the limb, not impede the blood flow. And someone can have a syncope, anxious, so it's desirable to put them in left lateral position. It is important to educate them not to run, not to drive the car, or not to walk after the bite. The limb has to be completely immobilized. It is important to remove all the clothing around the bite site and expose the area. So the bite site can have skin blisters. It is important that these blisters are not handled, And it is important to keep a close eye on a patient who is bitten. If he's developing any ptosis or anything of that nature, immediately they need to be notified to the medical team and acted upon. So it is important to make careful observations whether there is any neuromuscular weakness that may be setting in. So what are the things that one should not do? One should, after snake bite, one should not go chase the snake to kill it, because as I said, immobilization is the key. And it is important that one does not apply any sort of a herbal medications or anything on the site of the bite, or even consume any of these. And as I said, it is important not to have a tight tourniquet, because the whole intent is to uh, not impede the blood supply. And tourniquet is a big no, because it can lead to gangrene and so on and so forth. Because after a bite, there can be a lot of swelling and coagulopathy and devitalized tissue that can happen. So crepe bandage is something that is accepted. So you can put a crepe bandage and immobilize the limb. And at the site of the bite, it is suggested that no manipulation of the bite site is done with by applying gauze piece or by doing dressing of the snake bite or application of herbs, chemicals, and there's no role for anti-snake venom serum locally also. So after this, they come to hospital. The key investigation is the 20-minute whole blood clotting time. So it needs to be repeated every 30 minutes for 3 hours and every hourly up to 6 hourly until you see the blood, whether it is coagulable or incoagulable. So 20-minute whole blood clotting time is the key thing. So you have to continue ASV, and the screening for continuing anti-snake venom is to ensure that the blood is clotting. If it is not clotting, you have to continue giving the ASV. So, what are the general management principles? So, the crepe bandage or anything that you have put, it has to be slowly removed, because once you remove crepe bandage, there may be sudden flow of this venom up, and one has to be prepared for any hemodynamic collapse or respiratory distress that may set in after the crepe bandage or the dressing is removed. And feel for distal pulses, because there may be swelling and it may impede the blood supply to the area. So, one needs to be aware of that. And there may be a lot of pain. Analgesics has to be considered, but the definitive management is the anti-snake venom serum. So the full dose has to be administered without delay. In India, we have a polyvalent sera to cover for the crate bite, to cover for the cobra, and to cover for the viper, Russell and saw-scaled viper. So ASV is not effective against some of these snakes that are present in India. So hump-nosed pit viper, ASV is not effective. ASV is not effective against the Sochorex saw-scaled viper and on this crate snake, type of a crate called Kalat snake, which is present in West Bengal. So these are some of the unique snakes against which ASV is not effective. So how do we use ASV? If it is a vasculotoxic snake bite like viper or crate, there are two types of infusion that is recommended: low dose infusion and high dose intermittent bolus. So if it is a viper, for the low dose, the easy way to remember is give 10 vials stat and 2 vials every 6 hourly until whole blood clotting time normalizes. That is low dose. If it is high dose, total of 34 vials, 10 vials stat and 6 vials 6 hourly. So the easiest way to remember is 10 stat and 2 vials 6 hourly, or 10 stat and 6 vials 6 hourly until whole blood clotting time normalizes. And this whole total not to exceed 34 vials, because the maximum venom that can be present can be neutralized by around 30 vials. So that is the sort of ballpark. And the same can be utilized for even elapidate bites or the cobra bites. So once you start the ASV, they can have anaphylactic reaction. If they have anaphylactic, stop the ASV for some time, treat the anaphylaxis, but the quintessence is restart ASV. At no cost, ASV should be withheld or withdrawn. Even if they have anaphylaxis, you have to treat anaphylaxis and restart ASV, and then slowly increase the infusion rate. What about pregnancy? Even in pregnancy, the treatment is the same, ASV dose is the same, but only in pregnant ladies, gynecologist or obstetrician has to be involved to take care of the fetus and any other complication that may set in. So what about ASV in victims needing life-saving surgery? So you have to make sure that coags are normalized. So even here, so the ASV you give up to 30 vials, and 1 to 2 hourly you need to check whole blood clotting time, 6 hourly, to ensure that it has normalized before this patient can be taken up for surgery. So the key protocol is continue ASV and maximum up to 34 vials you can give 10 vials stat, 2 vials 6 hourly for low dose. If it is a very severe bite and you want to give high dose, it is 10 vials stat and 6 vials 6 hourly until whole blood clotting time normalizes. And you can reach up to 34 vials because conclusively it is shown that that should be enough to neutralize any amount of venom that may have been injected by any snake. So that is our understanding. So that's about the four protocols that I spoke to Nagaland. So and along with this, I had spoken about respiratory failure. And so we have prepared algorithms and protocols based on the whatever evidence that we have. So we will try to cover other protocols. So you can rehear to this by visiting my website www.drpradipangappa.com. Thank you, Vandu.